Flexion of the shoulder is a common action that occurs with both athletes and non-athletes alike. If the intrinsic factors affecting the shoulder are operating optimally, we should all be able to achieve 180 degrees of shoulder flexion without straining other body parts. However, when those intrinsic factors are not optimal, an overuse injury will eventually develop somewhere. The purpose of this analysis is to explore the potential development of an injury in this area. The preliminary intrinsic factors involved in the flexion of the shoulder are the bones and muscles themselves. The scapula and humerus are the bones involved in flexion up to about 80 degrees. After that, the sternoclavicular joint needs to be able to rotate, which allows the clavicle to get out of the way of the acromion process, so that the scapula may begin its upward rotation and get out of the way of the humerus as the shoulder continues to flex. The pectoralis major, biceps brachii, coracobrachialis, and anterior deltoid all directly contribute to the concentric contraction of shoulder flexion. The antagonistic muscles of shoulder flexion itself, which have to lengthen to allow this action to occur, are the triceps brachii, posterior deltoid, latissimus dorsi, and teres major. However, once the clavicle elevates and the scapula begin to move, it introduces other muscles to this equation. Trapezius and serratus anterior work together to elevate the clavicle and upwardly rotate the scapula. Their antagonists would be the rhomboids, levator scapula, and the pectoralis minor. These muscles are typically the only ones talked about when referencing downward rotation, or the antagonist to upward rotation. However, when looking at where the bulk of activity occurs within the serratus anterior, which would be around the inferior angle of the scapula, it makes sense to me for another muscle to be involved. The actions of serratus posterior inferior are to draw the ribs downward and backward, or in antagonistic terms, to keep the ribs from being drawn upward and forward. When looking at the ribs that serratus anterior attaches to, it sure sounds like serratus posterior inferior should also be considered as an antagonist. When these muscles have proper tone and the bones are in proper alignment, full shoulder flexion up to 180 degrees should not be a problem for anyone. However, there are many people whose muscles are out of balance and the bones are no longer in proper alignment. Therefore, much compensation is made in order to raise the arms overhead. Shoulder protraction is an easy position to relax into, but problems develop as we don't remember to retract our shoulders and come out of shoulder protraction. When the scapula is stuck in excessive protraction, there are problems of alignment within the joints and problems of contracture within the muscles, as well as additional problems within the nerves and the blood vessels, which we don't have time to get into. To start with the bones, a scapula that is stuck in protraction has an acromion process that is, essentially, too close to the clavicle. This proximity would impede the clavicle's ability to be elevated through the sternoclavicular joint. With enough time, this joint, the sternoclavicular joint, will become stuck, and vice versa. While the acromion process is no longer in the perfect place for the clavicle, it also changes the glenohumeral joint. In my line of work, I have found that a protracted scapula throws the humeral head anterior to its perfect location within the glenoid cavity. This sets the rotator cuff and the glenoid labrum up for a great deal of extra stress. These joint dysfunctions allow muscular dysfunctions to follow. Serratus anterior and pectoralis minor are the main muscles that do protraction. Thus, if the scapula is stuck in protraction, through logical necessity, these muscles would have to be short. This means that because of serratus anterior, the first rib all the way down to about the 9th rib would have tension put on them, at least along the lateral side of the body. Ribs 3, 4, and 5 would also be tight along the front of the rib cage because of pec minor. The tension within the ribs, along with the humerus being held anterior to its optimal position, would lend credence to having a short and tight pectoralis major. The anterior humerus and protracted scapula would also shorten the anterior deltoid, coracobrachialis, and both heads of the biceps brachii. Given enough time, A tight pec major might also induce internal rotation of the humerus, which would shorten the internal rotation capabilities of subscapularis, teres major, and latissimus dorsi, even though the anterior humerus would lengthen or stretch the extension capabilities of the shoulder. While these muscles in this position are too short, serratus anterior, pectoralis minor, pectoralis major, coracobrachialis, biceps brachii, teres major, and latissimus dorsi, their antagonists, by definition, are too long. Rhomboids, trapezius, posterior deltoid, levator scapula, triceps brachii, supraspinatus, infraspinatus, and teres minor. If half of the joint and its musculature are locked short, and the other half are being held in a lengthened position, the joint is thus set up to fail or to be injured. The question is, which half would be the first to get injured? The long muscles will certainly complain of pain or discomfort before the short muscles will. The experienced symptoms based on common client complaints are usually pain or extreme tension in between the shoulder blades or in the neck or at the base of the head. These are the attachment sites of where the muscles are being pulled or lengthened or stretched. The long muscles are being stretched out and they essentially run out of room to move because they don't have any more slack to give. It's possible that these already lengthened muscles could get overstretched and thus get torn. However, I think that it's more likely that in this position of shoulder flexion, the muscles which are locked short are more prone to injury. For example, when they are quickly lengthened or stretched out. A short locked muscle, which is then forcefully pulled out of its shortened resting position to a position beyond, will create muscle tears in that muscle. Sometimes micro tears lead to positive muscle growth. However, in this situation, a small muscle tear will develop, but most likely will not cause enough damage, which time or rest won't heal, so they say. RICE is a common acronym for healing a minor muscle injury. It stands for rest, ice, compression, and elevation. In my line of work, time doesn't always truly heal it, but rather time allows the brain to sequester the damaged tissue so that the brain doesn't have to deal with that injury right now. When I, as a soft tissue expert, touch that same tissue, I can tell you that it's still injured due to the tension and the scar tissue that have formed within the fascia, and by the tenderness in that area. Problems develop when that minor injury doesn't go away and the shoulder is still used in the same manner as before the injury. The micro tear that is there gradually turns into a bigger tear that will eventually impede the performance of the shoulder enough to seek intervention. But if we treat the short muscles as injured, even though we don't normally think of it as an injury, it could prevent the muscles which were too long from getting too long in the first place. In our particular example of excessive shoulder protraction, possible muscles that could be injured in this way would be the latissimus dorsi and the teres major. I realize that these muscles are not talked about a lot in regards to injuring them. However, my hypothesis would be that a minor injury could start here and be overlooked, thus turning into a major injury in other muscles if given enough time. I'm aware that if you're really trying to wrap your brain around what I'm saying, it sounds like I'm contradicting myself. In shoulder flexion, doesn't latissimus dorsi get long? Didn't I just say we should treat the short muscles first? As a quick review, a protracted scapula and an anterior humerus would lengthen the latissimus dorsi. Flexing the shoulder lengthens the latissimus dorsi. Internal rotation would shorten it. When raising your arms overhead, as in a volleyball block, my assumption is that you are starting out in a fairly fundamental standing position with your hands at your sides and your thumbs pointing forward. As you flex your elbows and bring your hands up to shoulder level, your palms become pronated. Your humerus should not be internally rotated, but the latissimus dorsi is already being lengthened. As you then flex your shoulders and extend your elbows, your shoulders become internally rotated. I already mentioned this gets tricky. As the shoulders flex, the lats should lengthen. However, this assumes a neutral humerus. Once the humerus starts to rotate, I think the latissimus dorsi gets confused. When looking at a computer application called 3D Muscle Premium 2, the artistic rendering of the lats suggests that internal rotation within this muscle only occurs in the upper fibers of the lats. Shoulder extension and adduction use the entire length of the muscle. So if all the extension and adduction fibers are already as tight as can be, it doesn't leave much room for the superior fibers to get shorter and tighter. It would be easy to just address something simple like posture and tell the client to stand up straight and hold their shoulders back, and it should theoretically be easier for them to lift their arms. However, without relaxing the passive resting tone of the muscles and other soft tissues within that kinetic chain, the muscles in question aren't able to just return to normal pain-free range of motion. In this video, Julia is demonstrating the effects of having short shoulder extensors. She goes to the end of her flexion range of motion and is attempting to internally rotate her humeruses. You see that she stops very short of 180 degrees of shoulder flexion. But in order to get just a little bit higher, you can see that she also hyperextends her back. If forced to operate with these short muscles long term within this abnormally normal range of motion, it would be exposing all of the muscles that cross the shoulder joint to increased friction and compression forces. And the client will begin to complain of shoulder pain or discomfort, or they will present with worse symptoms that need more immediate attention. So flexion is indeed limited by the extensors, but then add a bit of rotation to that and you might get a small tear, and our protective mechanisms will tighten everything up, which could eventually pull the shaft of the humerus back into extension, but leave the head of the humerus anterior to the glenoid fossa. This could increase the tension and decrease the stability of the rotator cuff muscles. With her relaxed posture, it looks like Julia is able to flex and internally rotate her shoulders just fine. Her brain has figured out how to accomplish these tasks within her shortened muscular resting tone. However, we saw earlier that when she takes her scapula out of protraction, the muscles are short and don't know how to move through that new range of motion. So even though to an untrained eye, it may look like she doesn't have a problem, over time, her shoulders will begin to show wear and tear. To a trained eye, they already are. So the question is how to treat the injury or how to prevent the injury from happening in the first place. In each phase of shoulder flexion, the joints need to be addressed to help correct the alignment causing the excessive protraction. Then, all of those muscles also need to be addressed to make sure they are relaxed and as fully functional as possible within their entire range of motion. Once the joints and muscles are as fully operational as possible, then strength training will have the greatest effect. There are certainly other issues which could affect the ability of the lats to work. There is a transfer of energy from the opposite gluteus maximus, so anything that affects the sacrum or the glutes on the opposite side could hinder the lats. This is an intrinsic problem to the body, and yet it's extrinsic to the shoulders. Weather is another extrinsic issue. If you already have shoulder issues and arthritis, then cold weather could make it more painful and more difficult to move the shoulder into this position. In volleyball specifically, the speed of the ball, as in a spike, could force the shoulder into hyperflexion and tear the shoulder extensors or even the back where the lats attach. While this particular movement is sure to also damage the glenohumeral joint and the muscles that cross it, it could also damage the muscles that attach to the rib cage. If the injured rib cage then and its muscles aren't treated, they could prolong the rehabilitation of the glenohumeral joint and of those muscles. Possibly for this reason, you're not allowed to block a serve in volleyball. Shoulders can get injured in a variety of ways. We can't control the extrinsic factors, but we do have control over the intrinsic factors, especially when treated early enough.